TOS patients come to us trying to avoid surgery. And there's a whole world of conservative therapy out there for patients with neurogenic TOS. Hi, I'm Dr. Scott Worden, the TOS guy, and we are live streaming from beautiful downtown Sunnyvale, California. And today we have three experts in conservative care who I would like to introduce to you right now. We're going to start with an old favorite of ours. Steve Talikowski is a physical therapist in the San Francisco Bay Area. He's worked in Hayward, California over several decades. He worked for many years with a known expert in the field, Peter Edgelow, and he's carried on the tradition with the INVEST program. Steve is highly regarded and experienced in helping patients with Thoracic Outlet Syndrome. Kenny Minot is in Atlanta, Georgia, working at Emory. He's a physical therapist and an athletic trainer. He's worked with Emory, a great university, for several years, for 10 years, I believe, and he's been active in the treatment of TOS patients for the past 4 years. Dr. Rachel Hollander trained in family medicine and accomplished board certification in 2011. Congrats. She subsequently earned a Master of Public Health degree in 2012. She's practiced primary care for over a decade in California. And beginning in 2022, after she had suffered upper extremity pain, she was diagnosed with Thoracic Outlet Syndrome. She recovered with a very unique technique, which she has invested in now and is going to share with us, called neuroplastic therapy. Hope I'm getting that right. She trained with a well-renowned, very prolific researcher and practitioner, Dr. Howard Schubiner, and she's got a virtual coaching practice called Hollander Holistic Health, and she guides patients and clients of all ages worldwide in self-healing from chronic pain, fatigue, and a lot of other conditions. Her coaching techniques are based in pain reprocessing therapy and emotional awareness and expression therapy, and we're going to learn a little bit about that today, and I think a lot of patients will be excited about it. So welcome all of you. Really appreciate you being here. Kenny, Rachel, and Steve, thank you.
Thank you.
Thanks for having us.
Kenny, I'm going to start with you. You've been with Emory as an athletic trainer and a physical therapist for quite a while now, for 10 years, I believe. And for 4 years, you've been seeing TOS patients. Let me ask, what is unique, in your opinion, about TOS patients compared to a lot of others that you see, particularly athletes?
What's interesting is they all present very differently. Every single one of them I treat, you're having to really just meet them where they are. You're having to just really understand, how long has this been going on? How acute is this? I would say on average, most of the patients we're starting to see, I'll initially assess, they've been dealing with this for six months or more. Over the last probably year to 2 years, we're starting to see patients earlier and earlier. We're starting to get quicker diagnoses, but I think that's due to the team that I'm with and them being primary, the doctors being this emphasis and people knowing who to reach out to. So we're getting quicker diagnoses. But what I think is unique is they've already been dealing with this for quite a while, and we're trying to unravel what they're going through, what they've done, what they failed, and then what can potentially work in these patients.
Now, I know you're part of a great team with Robbie Bowers, Dr. Eric Wagner.
Absolutely. Yeah. And we definitely work as a team, and it's interdisciplinary. And I'll even throw in there our vascular surgeon, Dr. Dewari. So when we are having possibly vascular cases, or if we're dealing more with the scalene and first rib, he's going to be the fourth member of our team that we're communicating with and we're working with just as a team.
That's really great. We talk here a lot on our channel about multidisciplinary technique. I don't know a single TOS specialist who can handle this all by herself or himself. So I think that's very encouraging. And I will also vouch for you guys that when we have patients who go to Emory, they get a very thorough, comprehensive workup, and they all feel like they've been evaluated individually. So it's a good program. Dr. Hollander, you are an MD, you have an MPH degree. Let me ask you the same sort of question. What is unique to you in your practice about TOS patients?
Yeah, I think it is very unique in this space because the way the model is very different, the neuroplastic model. Symptoms really start in the brain and nervous system. So we want to think about, well, what was going on in someone's life when symptoms began? Because chronic stress and emotional suppression essentially condition neural pathways for muscle tension and reduced blood flow in the body. So symptoms are very real, but a different upstream foundational cause is part of this model.
Do you see, would you say in your expertise, and a lot of this is new to me, there are patients who start with neuroplastic changes, central nervous system changes, and other patients who start with physical changes? And if so, what do you look for with those patients?
Well, as you know, for so long, it was thought TOS was very rare. And I think what still is rare is when it's solely physical. Usually that's going to be a really acute, serious situation, emergent. But so many people now are diagnosed with thoracic outlet syndrome when they have upper extremity pain and weakness, as I was, when it's not exactly the way that people used to be diagnosed with that with really clear criteria, really clear objective evidence. So I'm not sure if I'm trying to get back to your question.
Oh, you're doing great.
Can you restate the question?
Sure. It's kind of the idea of how many patients start with central nervous system disturbance versus physical disturbance.
Okay, yeah. So really it's about how the brain creates associations. This is not a conscious situation. We're not consciously saying I want symptoms, but the brain creates associations. So I developed symptoms while I was working a really stressful job as a family physician, about 60 hours a week, rapid fire pace on a computer at all times on the computer. And so the brain is frustrated, right? At that time, I'm not taking care of myself. I can barely eat, barely go to the bathroom, frustrated, fearful. Am I doing everything right? And so in combination with that situation, the brain is sensing a lot of computer use, and it's going to put the emotional tension into the body part that the brain is most aware of. So I think that's why I was a little like, let's get back to that question, because it's really both. It's both at the same time, physical and central.
So many patients who might get treated surgically with TOS aren't going to recover because of these changes in the central nervous system.
That is why, in my very confident opinion, certain patients don't get better from surgery, or they get worse because the brain has such a heightened alarm response.
And I would remind our viewers, and as all our specialists here know, not too long ago, patients would not be diagnosed for 10 years. They'd be seeing 6 or 7 doctors. Can you imagine the changes their remodeling did, their central nervous system? How would those patients ever recover to the well state? So what you're doing is really fascinating. Do you see many patients post-op, or do you tend to see them before they go to surgery?
I see such a wide variety of clients. I call them clients because it's all health coaching. By the time people see me, including this audience, you've seen so many different practitioners and getting all kinds of different answers. So you've essentially ruled out that there's something acute and serious that needs to be acted on right now. And you're left with, well, now do I get elective surgery because this is just hanging out for years? And so I see such a wide variety of clients who have all kinds of different chronic pain. And it really helps to understand the brain and nervous system. When we're thinking about the brain and nervous system, it's pain, it's chronic pain. It's not just arm pain. Someone else may have pelvic pain. Someone else may have back pain, but all chronic pain is generated in the brain in the same way.
So some patients will start with a physical disturbance, a motor vehicle accident, an injury while rock climbing. The physical part can be treated, but the mental, emotional, physiologic nervous system part may be ignored.
And the body is really good at healing itself after 6 weeks or 2 months or so. We can have a broken bone and the body heals itself generally. And when pain becomes chronic, then it's not from pain chemicals being produced at a site of tissue damage. At that point, it's a neural circuit that is in rerun. The brain has learned, okay, this is an area where that's been injured and had pain before. And if there's ongoing emotional stress and belief that you're broken physically, it will propagate the ongoing pain in a chronic way.
And you suffered personally through that, which I want to cover in a little bit, if you want to share.
Do I
Steve,
saffer personally with chronic pain?
you did.
I did. I don't now. So what happened? I was in this audience's situation 4 years ago. I was trying to search for answers. Here I was, a physician, and I still couldn't figure it out. Although I had the diagnosis of TOS, I did the imaging, Dr. Worden, your imaging, and you said I had the smallest costovertebral space you'd ever seen. And I had set up surgical consultations around the country. Luckily, before I ever saw any surgeon, I learned about the neuroplastic model. I happened to come across, I watched an hour's worth of free videos from Dr. Howard Schubiner online. He's kind of a forerunner in the neuroplastic world, research practitioner, everything. And so I watched an hour's worth of free videos, and my pain was 80% gone the next day because everything made so much sense in light of my understanding as a physician, all the patients I'd seen with chronic pain and other types of neuroplastic symptoms. So everything made so much sense. And then I practiced what's called brain retraining and emotional processing to get better over months. And now I'm fine. I can play the piano vigorously. I can do whatever I want.
That's an awesome success story. We love to hear those. Steve, you work a lot you start out with patients, and if I am not misstating, because it'll sound terrible to you because I'm simplifying, but the INVEST program starts with relaxation, breathing control, biofeedback. Is that correct?
It's true. Yes. Oh,
and how does that match up with, the neuroplasticity approach?
Well, I love to hear what Rachel's saying, because I think I've probably been seeing TOS patients for 28 years, although, probably more 20 with the last 20 years, much more often. And there's such a wide range of reasons why people have thoracic outlet syndrome, if you even want to call that. I mean, there are mechanical problems, there are postural problems, there are, cervical, other mechanical issues, but stress and loss of hope and, the loss of control is a big part of the problem. And that is part of the INVEST program. So even though there are definitely exercises that are mechanical and physical, I'm learning more and more as I start to practice that there's a huge emotional component to this. It doesn't mean that people can't get better with surgery. I have patients that do get better with surgery. There's people that just get better because we're working on posture and breathing exercises. But then there are people that struggle. And so there's a commonality there. I think there has to be, because that's why it's a syndrome. There has to be something similar that we can start with, but it's not a recipe in any way. It's a challenge to figure out which pieces someone needs. And as much as I feel like I've learned, and I think I've learned a tremendous amount over the years working with patients, I still see gaps in my understanding of it. I still feel that there's things that I need to understand. Stuff that Rachel's saying makes total sense. I've been doing some recent stuff on the polyvagal theory because I think there's something there.
What is that?
That's like the kind of the sympathetic parasympathetic system. The body's on sort of alert all the time. There's the parasympathetic, which is the relaxation part, but it's also there's a dorsal parasympathetic, which is a shutdown when you're really threatened. So it gets into like where are people in their as they react to these not just the injury itself, but just the emotional impact of losing their life, losing their livelihood, losing their, their ability to do basically anything. And so I could go on and on, but I just feel like there's, it's hard to just put people into a category. It's impossible, actually. And my goal is just to kind of find them a direction for them to move in. And I think I'm getting better at that, but there's still more there.
That's great to hear after so many years of practice that you're still working and learning and getting better.
Yeah.
Kenny, I have been surprised by the number of times that a patient came in for something else and a physical therapist was the first one to make a diagnosis, despite physicians being seen before. Does that happen to you with any frequency, that a patient comes in with a different diagnosis and you start to suspect TOS and then discuss it with the docs you work with?
It does. I would say having honestly having Dr. Bowers, especially on our staff, I'm probably getting it less because he is actually helping to diagnose a lot quicker. But absolutely, I mean, you get these cases where the symptoms just don't match up. You're running them. I mean, honestly, even all the special tests that we have for TOS, they don't have great specificity or sensitivity, and they're really not that reliable. But you absolutely will see these patients, and we're lucky as PTs that I have 45 minutes to an hour with patients, and I may or may not see them, once, twice a week. And being able to see them with any frequency and prescribing things, you get to see what is the reaction that they're having. And, if it's not the first thing in my head, I get to see them a second time or two, and then I can say, okay, why didn't they respond like I expected? And then continue to evaluate, and then try to narrow my field down and understand what's going on. So absolutely, it 100% does, because like you said, it's or even um, Rachel alluded to this, that these patients have seen multiple providers oftentimes. I do think lately it seems like we're getting better at recognizing it and better at diagnosing it across the board. But it's absolutely something that gets missed so many times.
That's great. The point you made about getting to spend more hands-on time with a patient, that's got to be tremendously helpful. A lot of physicians don't have that luxury.
No, they don't, and we can oftentimes be kind of their eyes and ears a little bit more, and really provide them impact. And it's so helpful to have an interdisciplinary team. So I can text Dr. Wagner, Dr. Bowers, whoever, and provide them with my own insight. If give them information, kind of tell them, hey, um, either this is a new patient that I'm worried about, or somebody we're already working with, and hey, these things are changing for the better or for the worse. And it's super helpful to have a team, for sure.
That's so important to those patients that you help steer the right way. Just think about how important that is, so they don't go down some far-flung direction.
Absolutely.
When I first started doing this, and it's probably been longer than any of you, man, we met patients who were 20 years into it, no answers. Can you imagine how emotionally challenging that was, and how many adaptations they had to make in their life? And I can only imagine their central nervous system, how much that had adapted almost permanently to the sick lifestyle. It's sad. I'm going to remind our viewers, please subscribe and hit the little bell, because that means you'll be notified whenever we do a new video. And if you haven't hit the like button, you should hit the like button, if not for me, then for these three people who are volunteering their valuable time and teaching me a lot. And I hope everybody else is learning too. So subscribe, hit the bell, hit the like button, comment. Comments really help us too. Everything with the algorithm. We're trying to spread awareness as well as knowledge. And we love working with patients. So Rachel, Stephen mentioned the balance between sympathetic and parasympathetic. Do you think this is part of the neuroplasticity that you can help work with?
Definitely. So most people who have neuroplastic symptoms, like neuroplastic pain, which I'm grouping TOS in, are people who have had perhaps even a lifetime of being kind of hypervigilant, being on, trying really hard, people pleasing. And so the brain is always on kind of heightened alert. And at some point, that kind of spills over into dysfunction in the body or pain.
So you're saying type A people? Am I assuming that correctly?
Well, I'm a type A I mean, I don't like to make that kind of label, but we grow up with challenges and we respond and adapt to those challenges in ways that make sense because of what's going on at the time, where parents don't get along. And so we try to be the funny one or the smart one or please people, or
Right.
someone's ill in the family and we take care of them. We take care of everyone besides ourselves. And so mind body symptoms or neuroplastic symptoms really develop when our experiences and behaviors are not aligning with our needs, beliefs, or values. And so essentially the brain is primed from a young age to then at some point it's just too much. And so for me, when I was working as a family doctor, and I have to say I was disillusioned with the type of work I was doing. I was seeing patients not getting better with the way I was trained, potentially getting worse, and I was working too much. So nothing was aligned there for me. And I grew up with challenges with a disabled father. And so I had learned to try really hard and to put others before myself. And at some point that just was my brain, my unconscious brain was like, no, this is a message in the form of your body, Rachel. This is too much. This doesn't make sense for you.
Wow, that's fascinating. So in your evaluation and your ongoing work with some patients, you're dealing with almost family counseling. You're dealing with these emotional issues like a psychologist.
There's a lot of overlap. Yeah, I'm not a counselor per se, but that's why I practice as a coach. In the first couple of visits, I really ask about what was going on in life when your symptoms began, and tell me about childhood and thereafter in terms of any significant life events and relationships with family members and all of that, because all of that is so important to understanding someone in a really holistic fashion, to helping them with potential journaling prompts to get at emotions. A lot of people just push on with things in life and they are just not addressing emotions. And emotions are energy in motion. They have to go somewhere. And in the brain, emotional pain is processed in the same way as physical pain.
That's fascinating. Steve, I know you see some post-op patients. Do you think you see enough post-op patients, or do you think there's opportunity, if more surgeons knew about it, that you'd be able to help more patients recover more quickly and more fully?
I mean, are you asking if I could see a post-op patient, would they have a better outcome?
Well, I know the answer to that.
Yeah. Well, I don't know. I mean, my biggest, I'm going to say my biggest gripe about what people are going through as far as PT is that everybody's in this no pain, no gain sort of mindset, push through it. So that certainly applies to, kind of my, before surgery patients. I mean, my patients I see, and then even after surgery, there's a push to kind of be aggressive. But I think, I'm probably try to be more aware of, like, there's still a sensitivity, there's still issues to be worked through. I don't start typically with the emotional stuff at the beginning. I don't think that's that's not where I start. I might end up there at some point, but I don't start there because I'm here to. People want the invest program. They want, my experience. They want all that, and built into that is my understanding of the emotional parts. But I'm focusing on, about postural awareness, about managing activity, what kind of exercises are good, what kind of exercises are going to irritate things. It's okay to say, I can't do this. It's okay to stop when it's too much. Flare-ups keep happening and happening and happening. We got to stop that from happening. And so it's kind of managing sort of a lifestyle as well. But I'm not sure if that really answered your question, but.
Well, my question is, I guess I'll restate it. Do you think it would be better if more surgeons were aware that post-operative physical therapy from an expert like you is a valuable adjunct?
Sure. I mean, I think the issue is always if you're going to see me, then you got to get to me. So, and we're in the Bay Area, so I have patients that'll come to see me, and then they have surgery and they live an hour away, and it's like kind of a hassle to get to see me. So then they have to see somebody else, and I'm always willing to work with their therapist if they want some guidance. Some people do, some people don't really care. Um, but I think it it does seem like a bit of an afterthought at times. This, oh, just get therapy. Well, we did the surgery, so you're supposed to get better. And I think there's still more to be done. Um, but sometimes it's just not, I don't know where they're going to go to get that. It's surprising how few people really understand this problem at all. And so it's tough. It's tough to get, the right therapy on either end, the beginning, the middle, or post-op.
This is kind of seem an oddball question, and and probably people who work with us know we refer a lot of patients to you because of our regard for your ability. Your empathy with patients is great. Having been a patient of yours myself and knowing patients, when you are empathic and so you're a good guy and you're so invested and interested in your patients getting better, and then you teach them to regain control, even if it's through physical movement, do you think that secondarily that it has that psychological effect of patients regaining their independence, their sense of who their well person is, who they used to be?
I like to think so. At least I like to think I start them on that path. I mean, they have to believe it themselves. I mean, Peter's program was a lot on sort of self-empowerment and,
Mhm.
understanding, being able to measure. And I'm a big person, and I think we can get into this about measuring objective improvement because, you know, people are going to look better before they feel better. We're talking about just the kind of the traditional process of going through the invest program. Um, but I think when someone feels like someone um, understands their problem, maybe has an answer, I think that's a big step in the right direction. Then at some point they've got to kind of believe it themselves.
Yeah, and
But to
Peter,
give them
Peter
that,
Edgelow, you referred to, he was just such a
yeah,
prince of a person. He was
right,
just so positive that,
right,
you know,
and you just make yourself available. You're there for a question. People get my email. They can contact me if they have something going on. I have both patients that will contact me and ask me a question. I just want to feel like I want them to feel there's somebody there that will help. And if I can lead them in another direction too and refer them to somebody else or say, hey, I got this person, Rachel, she kind of gets it too, and Kenny gets it. And, um, you know, I think you want to be part of this group of people that want to help, and I think when people find that group, man, it's really it's a it's quite an experience. I mean, I know it's still a long way to go, but they've spent their whole life just hearing, I don't know what it is, I don't know what to do, you're nuts, you're crazy, I can't help you. And
I
they can
think
finally
I
hear
think
somebody
Kenny's
say, I can help. That's
yeah,
amazing.
Kenny started us off today by talking about, the patients who come in and get empowered by that. Kenny, are you surprised by patients who say, I've never heard of this?
Um, am I surprised or
Yeah.
um
I mean, and how many of your patients come in and say, I know about this, but I didn't know I have it, versus the ones who just say, what the heck is that?
yeah, majority of the time it's what the heck is this? But I've been really surprised at how empowering it is for the patients to really have to really feel like they're being heard and to feel like they have a team. I think that definitely, I mean, how can you measure how much of an impact that really has? I don't know how to measure that, but it's absolutely something that you can tell that they feel they feel a little bit more at calm just knowing that they have somebody that understands it. And I have so many patients that are so well versed, and they will read literature, and they've read textbooks, and they have done so much of their own
Great.
research. It's incredible. And I mean, I think that is large in part due to the chronicity. Oftentimes, if these has gone on for 6 months, a year, 2 years, 3 years, they're looking for answers and they want to understand. And I've been so impressed, compared to probably most other orthopedic conditions I see. They will do their due diligence and try to figure out, a way to help themselves if nobody else can or will.
It's not even due diligence. No one's expecting a patient to learn this
Yeah.
much, but yeah, I'm shocked sometimes at how much effort they put into it, which reinforces
Yep.
what you're saying. They want control,
Hmm.
which
Well, yeah, they
again,
feel like it. They feel like it's out of their control. I mean, absolutely. They completely feel oftentimes. I mean, it goes back to this emotion. I mean, this is probably the condition. I don't know if Steve only sees TOS. I see a mixture. I mean, I see a lot of TOS, but I also see multiple orthopedic conditions, and it's by far the condition that's brought the most tears in the clinic. I mean, absolutely, because it's, either it's happy because they feel heard, it's sad because, like Steve mentioned, they feel like their identity is lost. They feel like I've lost a career. I've lost, I mean, I've treated a bunch of dancers that they feel like that was taken from them. They can't dance anymore. So, I mean, it's absolutely something that if we can offer just a little bit of hope, I think that can go a long way.
that's a great point. And you see athletes at Emory, a lot of good high level athletes.
Hmm.
So
Yes,
that
sir.
threat about losing that skill set, that career, it's a big one.
Yep. Goes to everything from an athlete to a homemaker to anybody.
Yeah, Rachel had briefly shared, but I have had some back issues recently, and Steve, as you know how much I respect him, he was helping me with that to start, and we're still going. And boy, it makes such a difference to have a provider who has time with you, who's, I'm trained, I know nothing about the stuff Steve is doing, and he's teaching me all these things, and it makes me feel like I have tools and I can see the light at the end of the tunnel, if that makes sense.
Mhm.
Just a
Absolutely.
amount of time you need.
Yeah.
I was just
And
about to
hopefully
ask,
if we can, oops, sorry.
no, go ahead, please.
I was gonna say if we can, I mean, that's probably the biggest thing we can do is empowering them, providing the tools, because it's definitely not the treatment that you do in PT and then immediately you're saying, hey, do you feel better? Is this a quick? It's not like that. It's assessing, kind of week in and week out. So it is an investment by the patient for them to trust you and for them to go ahead and believe in your treatment and to really be dedicated and stick with it. But if we can provide those tools and can hopefully slowly see some change, that's the best thing we can hope for.
So when you see a patient in clinic, not only are you examining them, you're teaching them the rhythm, moving their body correctly again, but you're giving them exercises to take home. So the work extends beyond when you're just seeing them.
100%.
Do you use nerve glides or like upper limb neural tension tests, that sort of thing?
For treatment, I honestly have not really found that very therapeutically beneficial in my experience. That's typically something that I find flares them up. I've honestly, I've tried it when nothing else has worked, but I don't personally find that works.
Do you see patients after Dr. Bowers does these selective injections that he does? Do you work with the patients differently after that kind of injection?
It helps me to narrow my field sometimes. So for those that aren't familiar, we basically Dr. Bowers tries to do a diagnosis of exclusion. So we do staged injections. Well, he does staged injections, not we. Let's get that clear.
Right.
So we will first do a lidocaine injection. So he'll either localize it to the pec minor or to the scalenes. Sometimes he'll hit a few other spots, but those are the main two. He'll ask the patient to self-report. What's your experience? What percent better did you feel like you did? And on those days, he'll ask them to go do everything that bothers them. So that way we can get a true report of what the improvement is. Now we'll tell them that only is basically a 12-hour experience, but that just helps us to understand. So we'll do the scalenes 1 week, the following week we'll do the pec minor, and then depending on the response, we'll get the Botox injections to one or both of those areas, depending on the patient response. The goal is that within the therapeutic window of the Botox medication, which typically takes about 3 to 4 weeks to really have a therapeutic benefit. Ideally, that's reduce pain, reduce sensitivity, improve function. I mean, I have people right now that couldn't lift their arm above shoulder level that are starting to just do daily tasks of reaching into the cabinets, whatever.
Okay.
So ideally, it does change with them if they're not as symptomatic. That's the biggest thing. Then it allows me to open up my exercise routine and hopefully basically build better postural endurance, better strengthening, better scapular awareness. Because if we're a little limited because of pain sensitivity, pain intensity, whatever it is, and that limits our therapy, then ideally that will allow us to have basically an 8-week window to, I don't want to use the word aggressive, that's not the right word, but an 8-week window of better pain tolerance so we can be a little bit more effective. Is
And maybe you can break up some of the vicious circles that patients
That's
get
the
into.
hope. Yes, sir.
Just
That's the hope.
I know it's a little off topic for our patients who are listening. We talk about injections with some frequency. What Dr. Bowers does is not do the subclavius, the pec minor, the anterior middle scaling muscle all at the same time, because if you get a positive result, you don't know which injection gave you that positive result. And we also talk about the transition between lidocaine, which is diagnostic, it only lasts a short time, versus Botox, which is therapeutic and can last 4 to 6 months. Although it wears off, each successive injection has less effect. And I've also talked about just what Kenny's sharing with us, that it gives a therapist less pain to overcome and more freedom of motion, and can really have breakthroughs in treatment. So that's off our topic. Rachel, how long do you see, not your average patient, but what's kind of a range of how many times you see a patient and for how long that you think gives you a good chance of success?
Yeah, it takes time to self-heal because it's all about many pieces. The pieces are learning about neuroplasticity, how the brain and nervous system work to create symptoms in the body, and making lifestyle foundational changes so that you're more empowered and you're being more aligned with your needs and your beliefs, as well as emotional processing and brain retraining techniques to reassociate what was fear or frustration or negative associations with your arms, essentially. So it can take months, weeks to months to begin to see some improvement. So it takes a lot of openness to the neuroplastic model on the part of the client. But usually people will see themselves in the ideas and they will dive in. And they may have questions about, well, what about this? I heard from my doctor, or this from, on the imaging, this result, what does this mean? Is this truly just structural? And so we'll talk through that. And people are really empowered to be their own self-healers. They use Dr. Howard Schubiner's Unlearn Your Pain workbook or another guide. There's many apps, Curable, Free Me, Nirvana. There's lots of different resources in this space to help people learn and to build their evidence list that what they're dealing with starts really in the brain and nervous system. But it takes, recovery is sometimes months to even a year more because it takes a lot of life changes. For me, it took just over a year to get back to work after I learned about the mind-body model, because it's a lot of gradual re-exposure to the situations that were triggers before, but with messages of safety and understanding that, my arms are not messed up inherently. It's the tension that starts in my brain and the belief that started in my brain about what's going on downstream. And so you have to reassociate that. Almost like performance anxiety, there's ways to do gradual re-exposure, or fear of flying, gradual re-exposure in the setting of safety. There's some elements that are in common there.
Do you ever recruit family members as part of your coaching?
As my clients, or?
No, I mean, when you have a client.
Oh, a client's family.
Yeah.
Well, it's common that people do better when their family member understands neuroplasticity. I don't personally at this time lead workshops on that, but the Pain Reprocessing Therapy Center, I think it's called, in Southern California, does virtual workshops for family members so that they can understand how to better understand their loved one and to not add fear signals and that kind of thing.
So that's avoiding negatives. Can they also add a positive and support and reinforce what you're doing?
Yeah. When they understand that, we call them like the 7 F's. There's all these things that propagate symptoms, fear about the symptoms, frustration, trying to fight it, especially in a biomedical way, but also if you're feeling like there's a timeline or a pressure that it has to get better in a neuroplastic way, feeling forlorn about the symptoms and so on. You have to do the opposite. You have to lean in with curiosity to the sensations that you're having, see it for what it is, pain and discomfort, and try to reduce your labels for it. Because we've got spinal stenosis, we've got thoracic outlet syndrome, we've got chronic pelvic pain syndrome. I mean, all this is just kind of reinforcing that something's wrong in the body, but we just need to have positive messages from above to reassociate. And it takes time.
That's a great description. And for those who are interested, Howard Schubiner is spelled a little unexpectedly. Would you spell his name?
Yeah, Schubiner.
Now, one more thing. You work in San Francisco, but you see patients everywhere. Is that correct?
Yeah, I used to live and work in the Santa Cruz region, but now I live in Ventura County, but I work completely remotely. I see people.
Excellent. Would you all like to take some questions from some viewers? Please say yes.
Sure.
Right. So Herb, let's get a few questions we can answer for our viewers. All right. Shrew Teeth. Has scar tissue already built up by the time symptoms show that prevent return to normal? Does the body just not learn to readjust permanently? Rachel, can I kick that to you?
You can. I'm trying to wrap my brain around the question. So I'm not sure if scar tissue is from surgery for thoracic outlet syndrome. Is that kind of how you all are interpreting this, or scar tissue from something else? But scar tissue is often, in the world of neuroplastic symptoms, blamed for the symptoms. The body is healing itself. It creates a scar, whether it's a cut on the skin or after a C-section or any surgery. The body makes scar tissue to heal itself. Scar tissue doesn't release pain chemicals. The brain is not sensing pain because of pain chemicals released from tissue damage, because a scar is healed tissue. It looks gnarly, whether it's inside the body or on the skin. So it's a misunderstanding to consider that scar tissue is causing pain unless there's some really severe pulling or impinging on something. But usually that's not really the situation. But I'm not sure how else to understand
You've brought this up before that, and I understand what you're saying, that the pain in chronic pain is not because there's an ongoing injury to the soft tissue. It's that the brain has learned this pattern, correct? Am I stating it?
Yeah, it can be a combination of the brain has learned the pattern, as well as the brain is creating real downstream tension. Like on my MRI, you saw a real lack of space there. So I believe there was real tension in that area, and I believe it's a combination of factors.
Thank you. This is a further question from the same viewer. Why is reversing TOS so difficult compared to other injuries? Years-long cases make sense with scar tissue, but even relatively mild acute cases seem to require a lot of time and lifelong management. I'm going to answer part of this. We have seen, and Kenny mentioned this, in my experience, we've seen a shift in when patients come to a caregiver, a provider. I think there's raised awareness. I'd like to think that we played a small part in that because we're always talking about TOS here. I think that with the athletes and the internet, where people read about Victor Wembanyama or Zach Wheeler, the pitcher for the Phillies, as they went to the playoffs last year, as they read about the athletes, they get a lot of traction. And so I think the patients are coming to us earlier in the course of the disease, but that also means they're younger and healthier because they're not 20 years down the road. So I think we're shifting better. Now, the scar tissue, I'm going to assume from this second question, just what you did, Rachel, they're talking about not post-surgical, but scar tissue as part of the disease process. So if I'd ask you to answer why is reversing it so difficult, you've kind of answered it, that it's because it's not just a physical injury.
Are you asking me?
Yeah, I'm kind of trying to help. I'm kind of trying to read the mind of Shruti. So why, the question is, why is reversing it so difficult compared to other injuries?
I would say because probably in that situation, we're addressing the problem at the wrong area. Just like in this space, very commonly you all talk about, is it the pec minor area? Is it the costovertebral space and so on? Is it the scalene muscles? Well, is it the central nervous system? So if we're addressing it in the wrong area, we're not going to fix the problem.
And by the way, people have done scientific studies on the central nervous system and the changes in it. It's not just some assumption. There's been very careful peer-reviewed studies for anybody who's asking. Herb, have we got another question? And thank you, Shruti, for the questions. All right, 22 Tate, we know this viewer well. Thank you. For everyone with an extremely sensitive patient, what's your first strategy and therapeutic technique? That's a good question. So, Steve, what are your first steps?
Well, I want to say one quick thing though before. I think I'm going to answer that last question just for 30 seconds, but I see a lot of patients and I see them, they've been dealing with this for 3, 4, 5 years. So at one point it was mild, and it just got worse. And I think they've just gotten the wrong information. They've gotten the wrong treatment. They've approached it the wrong way. Not because they don't care, they just don't have the right information. So I think we could help people sooner. And maybe that includes physical parts, maybe it includes mental parts, but I think people are just going at it the wrong way. And then it becomes chronic. And then because it's chronic, all the issues that come with a chronic problem are here. Like in this case of a extremely sensitive patient, I need to sort of just kind of stop everything and say, we've got to get this under control. For me, the beginning part is we do a lot of stuff about relaxation, breathing, positioning, posture, but the rule is it's not okay to aggravate it. We have to calm it down. I use objective measurements like hand temperature, neural tension, not anything to cause symptoms, but just a way to assess where they're at, and to show that person that there is a way to, even with you're very sensitive, to sort of start the process of calming things down, because you can't just push through it anymore. It's just too much. And
would you
pushing
say
through it just makes it worse.
You're teaching the patients to gain control.
And it's okay to stop. It's okay to ask for help. It's okay to, take it easy, because there's a lot of pressure you mentioned about type A people, or I don't even know if it's type A, but it's just people that are they're used to working hard. They're used to giving, and they're used to being the one that provides. And now they're the one that needs the help. And that's a big step for some people. So to say it's okay, I literally have people, they're in medical care, and for them to ask for help is hard. And I'm going, but everybody asks you for help and you give it to them freely. So it doesn't, I hope I don't sound that way when I talk to them, but I sound more, but it's like, we've got to slow down here. We've got to take a break. You're going to get better if you do the right thing. I tell them, I believe you're going to get better if you do the right things, but we have to start doing the right things, and we have to stop doing the wrong things. And sometimes that's hard because you get flare-ups and you get discouraged. And then you got to talk people through the flare-ups, because if you didn't have flare-ups, you wouldn't have TOS. That's part of the deal. When you stop having flare-ups, you're getting better. So we got, so when you have them, it just means that that's where you're at in your process, and we have to, but no nerve glides, no strengthening, no weightlifting, no, I even say we're not even going to do yoga, unless you can prove to me that yoga makes you better. Everything has to be assessed. Every single thing has to be looked at. Your pillow.
It's fascinating. You
Sure.
brought up a few different emotional overlays. One is the people who've been treated for 3 or 4 years and they're worse. Think of what that does to somebody, that they're not going to count on medical care because it's failed for them. Even a doctor, a physiatrist, a physical therapist, a chiropractor who can help now has a lower chance because the patient has an unfortunate emotional overlay. The doctors don't help. And,
No.
and you brought up the role that people assume that healthcare providers can't go for help to other healthcare providers. So people who form a certain self-opinion, I mean, this is a lot in Rachel's bailiwick, people who have a certain self-opinion and a view of themselves with chronic pain, they change that view and it's not always healthy. Would that be fair to say, Rachel?
Yeah, you're saying the view of themselves as a patient or someone who needs help.
Right.
Yeah. Yeah, it is hard. But yet when the body, when we're being the helper so much, the mind is telling through the body what it needs. And we may consciously not want help, but unconsciously that's what we need. That's what the brain and nervous system needs.
So there are also the social expectations. A hardworking dad, let's say a manual laborer, just can't quit because he's got a family to take care of.
Yeah, when people feel really stuck in a situation, a relationship, a job, an obligation, they can be a real setup for neuroplastic pain.
Oh, that's great. That's great to hear. Kenny, what are your first steps? What's your first strategy, I guess, to assess a patient and treat a patient when you suspect TOS?
Depends. I mean, unfortunately, that's always the answer. Depends what's going on. I'm probably looking a lot more at the physical components. I'm getting an idea of kind of where they're at mentally, just as we're talking, as we're going through their subjective history, and I'm kind of getting an idea of where they're at. In the case of a very sensitive, let's just say their nervous system is extremely flared up. I'm trying to go through an exam, and basically every position I put their arm in or position I move them in, they're getting symptoms either locally, down the arm, what have you. I'm also a very big proponent of meditation. I'm not an expert on meditation techniques, but I do really believe in, like Steve was saying, is you need to calm things down. So I'm a big proponent in talking to them about meditation. Diaphragmatic breathing is something that I like to do a whole lot, especially, if I really suspect that in my experience, if it seems like there's something maybe more scalene driven, predominantly. But I'm a big proponent of lying on their back. Sometimes nothing underneath them. Depends how, if they're really sensitive, I don't use a foam roller. I don't use something behind them to open the chest. I avoid that. I just lay flat on the floor, arms kind of by their side, palms up, which is a light stretch, and have them in with a nice pillow, just neutral head support. Deep breathing, diaphragmatic breathing, and meditation is probably my favorite go-to. And if they're working, I mean, that's the hardest part, is if they're having an acute flare at midday, hard to get them to break that. If that's flaring them up, it's hard to get that broken. If they work remotely, they can always do that at home if their job allows. Maybe it's a 5-minute break of just lying down on a floor, meditating with some diaphragmatic breathing.
And the diaphragmatic breathing is to avoid the use of the scalenes as secondary muscles of respiration.
That's the idea. Yes, exactly. Because a lot of times, what oftentimes we'll see is that if the scalenes are a little bit overactive, the theory is that if the scalenes are active, they're pulling the first rib up. We're still learning if that's just more in a true structural sense, or is that just symptomatic? What is that that's happening? But that's the thought process. If they are accessory muscles that are overactive, then we want to try to basically get them to relax by teaching the diaphragm to take over. And it's the main respiratory muscle, but for some reason we need to really focus on engaging it sometimes.
I learned all about that from a local physical therapist here. He's in my upper right corner here, Steve.
Okay.
We talked
All
about
right.
that a lot. Thank you for the question, Tate. I appreciate it. Hope we were helpful. All right, True Teeth, again, for someone who works an arm-intensive or aggravating job, is it recommended they take extensive time off to recover? Is it possible to recover while keeping a job, and can reducing work be enough? I'm just going to, before I pass the question out here, I'm just going to say we don't answer specific patient questions here for obvious security and privacy reasons. Please reach out to us, and we're glad to talk to you and help that way. Obviously, this is a more general question, but I'll start with you, Kenny, this time. A patient who has a job that requires the use of their arms, extensive computer use at a non-ergonomic workstation, a house painter, a UPS worker, people who are disadvantaged. How much work limitation do you think typically needs to be provided?
It's a tough question to answer because in my line of work, we're usually expecting, we're usually wanting to treat people for about 3 to 6 months to really track and see, and depending on where they're at and what their symptoms are. I mean, my expectation is that therapy oftentimes will take a couple of months to see improvement. So to ask somebody to take off 3 to 6 months, that's a hard ask. Is it possible to recover? Possibly. Are there work modifications that you're able to make? Is your employer open to making those modifications? Are there things that you can do? I mean, I do think that it is possible to recover. Now, like Steve mentioned, if you're doing a job and you are feeling like day in and day out, you are just continuing to flare your symptoms up, then you may, then maybe not. Then it might be something that you need to consider some type of change to break that cycle. I would first look at modifications you can make with the employer. It's a really tough question.
No, that's helpful. Steve, do you have any additional thoughts?
Yeah, it's a tough question. I mean, I think, we always encourage people to try to continue to work. I mean, partly because they just have to and they need to. So how do you make changes within that, within their work system? How do you make changes at home? How do you change their mindset about what they're doing, outside of work? And I think, and I've had plenty of patients who continue to work and have gotten better. And I've had people who have taken time off. I've had people that have reduced their hours. I mean, at some point, if you truly hate your job, it's going to be tough to try to get back to that job. I mean, there's no motivation to get back to it anyway. So it's so individual. But people ask that question all the time: should I take off of work? And I'll just say, let's see what we can do first. Let's get solve the basic problems first, and see if we can, continue to have you working, getting better. And then, at some point, it's going to be up to the person to decide, is this too much or do I need it? But I think they can decide, hopefully with a more realistic goal or view of the whole thing. So, but keep people working if you can.
Thank you for the question. And I would say if your doc is not comfortable with TOS, definitely reach out to us. We can help connect you with these experts or others to get a great idea how to help you feel better. Thank you for the question. Brian Morris says, could you go more in depth on sleep and pillows? Thank you. Steve, you want to grab that?
Oh my God. If I could fix the pillow sleep thing, I'd be a billionaire. I think there's some obvious things, I look at, but my initial, when people ask me this, and this is another question they ask all the time, I'm going, let's take care of what's happening when you're awake. And then let's see if we can make some small changes. There's certainly a lot of new pillows out there today that might be able to give you some relief. But I think if you felt better, you'd sleep better. So I don't think it's the sleeping that's caused the problem. I think the sleeping is a problem because you have the problem. But there's some, so I'm not really answering the question very well, but I would say I'm focusing on what's happening during the day, what happens when they're awake. And then as people feel better, they tend to sleep better. But there could be some, but I mean, I have a half dozen pillows right now myself. So I'm still looking for the answer, but I found a couple that I like.
So again, close counseling with your therapist to find the best positions for you, and then find a pillow that's suitable to that.
Yeah, but really focus on the day when you're awake. Calm things
Rachel,
down.
does sleep quality change when people get into the bad cycle?
Yeah, insomnia itself is a neuroplastic symptom. You know, life, emotions, mental tension creates problems in the body so that you can't sleep. Depression and anxiety are neuroplastic symptoms. So everything that starts in the brain is a neuroplastic symptom. And so we'll micro focus on pillows and these little things. And you know, I would just say do what is as comfortable as you can have for you. But remember that if you are looking at it from the point of the brain and nervous system in the appropriate situation, then try not to over focus on those downstream, you know, modifications. It's really about calming your brain, making your life more in tune with what is true for you.
Thank you. Thanks for the question. And Herb, I believe we have no more questions at this point, if you'll confirm for me. So I want to thank each and every one of you, Kenny and Rachel and Steve. Oh, we have one more question. It's good. All right, we can't leave a viewer unanswered. Judy says, hi, I'm so excited to listen as my doctor wants to do a scaling release after a one-day diagnostic Marcaine injection. Yet it seems at time we have good days and bad days, and he doesn't do Botox. So Marcaine is a short-acting anesthetic. Again, we don't answer specific patients and specific medical questions, but we're happy to if you contact us through tosmri.com. Judy, so you had a Marcaine injection, and they're viewing that as an indication to do a scalene release. In general, again, I can't be too specific, the literature on scalene blocks, you have to take it with a grain of salt. The first paper was published in the early 70s in Los Angeles, and they took patients and they did injections under, I think, EMG, not even under ultrasound. And the patients who had less pain after a scalene block went to surgery. And so they kind of said, well, if you have a positive result when you inject the scalene muscle, you should go to surgery. But they didn't have a control group, patients who didn't have a positive response from the scalene and went to surgery and had the same outcome. That could have been the case. So people use it. Some docs believe that that's the easy answer, a 5-minute examination. I've said it before. When a doc examines a TOS patient, it's not a 5-minute examination. I've seen Hugh Gelibert, for example, at UCLA, he was doing this for so long, he's so experienced, and he does such an exacting examination, and nothing is an absolute, because right now in TOS, nothing is an absolute. I love what I do, but it's not an absolute. There are some things you need to look at in conjunction with it. So the scalene release by itself can be indicated by certain imaging findings, but I wouldn't say that just a scalene block by itself is enough to make a surgical decision. It depends on a lot of other factors. I'm taking that question myself, guys, because I don't know if anybody else wants to talk about scalene injections. Maybe Kenny, because you have experience seeing these patients. Would you like to add anything to that?
Yeah, I mean, without more information on this case, I mean, I would first kind of ask, how long have you been in PT? Have you been with somebody that's having a design structure? You know, if you haven't been in PT for a long time and your doctor does an injection and wants to release it, then I would probably pause and say, okay, what other conservative care? I just don't know from this question. If you are somebody that's having some good days and some bad days, I mean, is there some? I mean, I'm not trying to get you to leave your doctor, but is there somebody else in the community that your doctor knows that does do Botox, or you could reach out to? You know, is there a way to close that loop a little bit? If that's something you're interested in trying and would like to have that as part of your therapeutic model, I find that it can be very beneficial. You know, if you have access to that, I would maybe try to pursue that route. Again, it can give you a little more information. All I can say is this isn't I don't have evidence on the number or the degree, but in cases where the Botox has been also therapeutically beneficial, I've had certain cases where the effects of the Botox wear off, and the cases where they go back to either baseline or kind of back to their normal. I've had a handful of patients get that release because they did, in this case, in this example, they did have a very therapeutic benefit from it. It just, for whatever reason, didn't work for them. And then they had a pretty positive experience out of surgery. Now, I can't say that's how it will be for you, um, but I do think pursuing it could be beneficial.
And you brought up a great point there. You can keep your doc, your primary care doc, or your orthopedist if they want to be the quarterback of your care. I always say this, but
Yeah.
seeing specialists like our panelists here and having your doc back home put that all into their brain and into your chart and put it together to get a cohesive picture is a really good idea. You know, Kenny works with a multi-specialty team, and they work great together, but not one of them knows everything. That's why they have Kenny around to do his specialty and Eric to do his, etc. So I do encourage people to see more docs and get expert opinions, especially if surgery is considered. Thanks for the question, by the way. Tate has another question. This is great. As a TOS patient, I've had great success with neuroplasticity, chronic pain coaching. In particular, graded motor imagery has really helped me. Rachel, this sounds like it's a question for you.
Yeah, it sounds like a comment, but I'm glad that has helped you. And graded motor imagery, you know, there's a lot of different ways to say it. Essentially, graded exposure. You know, when we imagine things, it is 90% there to doing something. So, like if you're trying to learn anything, if you just imagine playing your piano piece, maybe your fingers are moving, but you're not really playing a piano. If you just imagine something, you're 90% of the way to doing it. And so you begin with imagining doing something that maybe was a trigger and you couldn't do, but you do it with affirmations. Hopefully you're truly in belief with it because you're understanding the neuroplastic model. But in combination with affirmations, you're giving yourself new safety signals, a new way that your brain is associating your arms with safety. So that's the idea of graded motor imagery. And then eventually, when that seems to go well with less symptoms, you can go to gradually doing different things with your hands or your arms that were a problem, very gradually, very slow. So it's a little bit different than pacing to completely avoid. It's pacing with the knowledge that you can get there, but we're just going to do it slowly.
Thank you. Herb, can we take two more questions maybe? Ann, hi Ann. Thanks so much for this discussion. My TOS was primarily resolved years ago with the Edgelow method. That's what Steve does now. He's advanced it. It's called Invest, using Peter Edgelow's kit. And I learned so much here. I'll look into the neuroplasticity approach. Thank you, Ann. And if you want contact information for anybody in particular, our doctor here who does neuroplasticity, please feel free to reach out to us and we'll give you contact information. All right. Each and every one of you, Kenny, Steve, Rachel, thank you so much for sharing your time and your expertise. I think this is one that will make a lot of difference for patients in understanding where they are and what they can add to their treatment. So any last words, Kenny?
No, I appreciate you having me. Thank you very much.
Thank you. Steve, anything for our
I would just
patients or viewers?
Yeah, just I think to have hope and know there are people out there that understand it. There's different ways to treat this, and it's it's finding the right person. And what I hope myself is that as I learn more, I can maybe even direct somebody to that other right person, because I think we all have a piece of this puzzle. It's just not there's not one person that can do it all. So we're all here to help in our own way.
I would feel very comfortable referring patients in the future to any one of you. And Dr. Rachel, any last words for your patients?
Yeah, thank you so much, Dr. Worden, for having me, because I think it's very bold to have someone like me on when the approach is very different. So I really appreciate it. And I just want to make it really clear to people listening that your symptoms are real, but it doesn't have to just be about coping. It can be an empowered self-healing process. It just takes your openness to the neuroplastic model. So feel free to look up. I have a lot of free learning information on my website.
That's great. What a positive approach. It's really refreshing, especially from someone who's gone through it themselves. So glad you're here. So thank you again, all of you, for your time. For our viewers and patients, reach out to us if you want any contact information for our specialists here. And don't forget, subscribe and like and help us spread the word. So closing out, this is Scott Worden, the TOS guy, and everybody have a great week.
Thank you.
Thank you.
Thanks.